All right, everybody, we're going to talk about diabetic emergencies and altered mental statuses today. This one isn't too bad to get a handle on, I don't think. Let's start off with some quick pathophys. In the brain, we have something that's called the reticular activating system. And we should be aware of this because it's responsible for things like staying awake and staying conscious and paying attention, being situationally aware, basically, of what's happening in the world around us at that time. It also deals with our circadian rhythm. It helps us to go to bed, when we should be sleeping and when we should be awake, things like that. Now, all brain tissue, all cells have certain requirements, but to stay alive, and the main three ingredients for all of those cells are oxygen, so we can get that to the tissue there. We need glucose, the sugar, to nourish the brain tissue, and then we also need water to hydrate it all. Now, obviously, all of the body's cells need these things there to stay alive, but the brain is particularly sensitive to a loss of either one of these things. And if we're missing any of the corners of this little triangle here, we can see altered mental statuses. So that's what's going on when we do get an altered mental status. For some reason, we're missing one of these three ingredients. Now, this isn't the cause of all altered mental statuses, but it can be causes. Losing one of these three key ingredients can be the cause of many of them. But it won't be the answer to all of the reasons somebody has an altered mental status. It can be caused by several things: deficiency in either the oxygen, glucose, or the water that we have. We can also get altered mental statuses through trauma. Maybe somebody has a head injury, infection, other toxins, drugs, things like that. Primary brain problems. So that means like direct problems with the brain. So like a stroke, for an example, would be a primary brain problem. That's a stroke is an injury to the brain. Or we could have another problem with another body system. So for example, let's say your patient's airway or the respiratory system isn't working real well for whatever reason. Maybe the airway is severely swollen due to inhaling superheated gases in a fire, or maybe because of anaphylaxis or something like that. The patient could be hypoxic because of those things, and that'll lead to the altered mental statuses that we can get. So it can be other body systems that cause this as well. Luckily, for us, a lot of altered mental statuses can be corrected, and sometimes quickly, if we can identify the underlying problem. An altered mental status is always a sign of something else that's wrong. It's always a sign. It's never the primary problem itself. It's a sign of something else happening there. So if we can figure out what that underlying problem is, then hopefully we can correct it. A great example of this is our hypoxia guy, right? Or four spades, that guy. Well, if you remember watching that video, that it was, he couldn't follow simple commands. He couldn't do very simple tasks. Yet, almost seconds after he gets an oxygen mask on and starts breathing in good oxygen there, that altered mental status was almost immediately corrected, right? Within a minute, the guy is maintaining properly. So, like we said, if we can figure out what the underlying cause of altered mental status is, it might be quickly corrected. Could be quickly corrected there. You just have to figure out what the deal is, right? What's going on in the first place. All right, so let's talk about assessing a patient with altered mental status. First of all, what we should know is that people with altered mental statuses could be a little bit dangerous to us, could be a lot of it dangerous to us. You look at folks like severely hypoglycemic patients, they can be a bit combative. We can have brain injuries, like head trauma folks, they can be combative with us. You know, these folks are not in their right mind at these times, and so um, um, they may be a bit combative, and they could put us in a dangerous situation. As always, as we've discussed many times before, the moment that you even start to wonder, like, am I going to be safe here with this situation? Then get law enforcement there. That's one of their jobs, is to help us out with our jobs. And so, if you're ever just have the inkling that, you know what, this might not be totally safe for me, get them there. There's no problem with that. There's no problem with that. They'll be there quickly to help out. You don't want to be in a bad spot, obviously. So always make sure you do a good scene size up. Make sure that you and your crew are all safe there. Use law enforcement when necessary, like you said. So when we're assessing folks with altered mental statuses, obviously we're going to go through our primary assessment first, and in A, B, or C, we could find reasons for somebody to be altered. Do we have an airway issue that we can fix? Is there a breathing problem that we might be able to fix through oxygenation and ventilation? So we'll look at those first. Obviously, they come in that order, airway and breathing, as we get into our primary assessment there. So we got to be attentive here when we're doing our primary assessment, because hopefully maybe we can figure out what the root cause of the altered mental status is at this point. And so be attentive there, figure some things out. Let's make sure that airway is patent. Let's make sure that we are getting signs of adequate breathing, and if not, we know how to fix that, right? Some positive pressure ventilations with the BVM, probably some supplemental oxygen hooked up to that as well, some high flow oxygen. Folks with altered mental statuses, they may not be able to protect their airway, so maybe it could be in the patient's best interest if we laid them down, say on the left side, left lateral recumbent, and then we could apply suction there to make sure that we keep that airway open. So always be on the lookout for that airway. As the patient gets worse with their mental status, maybe they're less able to protect their airway. And so if you're thinking to our medical sheets, where after we get done our secondary assessment, what do we state? We're going to redo our primary assessment. So that means we're keeping an eye. How is the airway now? It was fine 5 minutes ago. How is it now? Is it going to stay open longer for this patient? Is it open now? Will it stay open? Are two questions for airway, right? Obviously, hypoxia, if you suspect that, got any signs and symptoms of hypoxia, then let's give them some supplemental high concentration oxygen and get them back into a good mental state there. Be alert for indicators of hypoperfusion. Shock. We should all know that means shock at this point. If we do see signs of hypoperfusion, of shock, which are textbook almost, or basically, so we're looking for an altered mental status, looking for pale, cool, and diaphoretic skin as well. You can see some compensation efforts by the body, so increased rate of breathing, increased heart rate, that kind of thing. Blood pressure should be probably maintained until they start to decompensate, and at that point we're going to see them their blood pressure decline as well, so we can see a drop in BP. Try to figure out what the patient's baseline mental status is. What's normal for them? We may not be able to figure that out. Maybe we're in a store and this patient walked in and started acting funny, and nobody in there knows who they are. So that could be definitely a possibility there for that. So try to figure it out. If you got a bystander there, family member, friend, something like, we can figure out, all right, how different from normal are they? And then we figure out what their baseline is for where we are today. Because we're going to have to show, hopefully we can show change, hopefully in a positive direction here after we've had some interventions. But figure out what that baseline mental status is for a patient. This can be tricky for a number of patients. So like, for example, if you go into a nursing home and your patient has been battling, let's say, dementia for a couple of years, maybe their baseline is highly altered. And it's not normal, probably hasn't been for a while, that kind of thing. And so we're going to have to try to figure out through bystanders there, the nursing staff, things like that, how exactly this patient operates, what their baseline level is. So it can be a little bit difficult, but it's just a little bit of detective work that we'll have to do there. So, and that detective work for you is going to be follow-up questions in your secondary assessment, OPQRST, sample, that kind of stuff. So, as we know, we always try to get a baseline mental status on every single patient, and we do that using ABPU, right? And so we introduce ourselves, we ask them what's going on, and while they're telling us what is going on, why we're there, that kind of thing, we're observing how they react to us. Do they talk to us normally? Are they answering appropriately? Are they using the correct words to answer your question? Are they using nonverbal cues in their communication to show you that they are with it? One of the things that maybe we take for granted, but when we're having a conversation with somebody, we make eye contact, right? It's one of the things. So do they make eye contact? Do they look at you when you walked across the room? Are they looking at you while you're talking to you? You can tell a lot by just those that simple nonverbal cue there. So we're going to greet them, we're going to give them a chance to talk, and we're going to kind of be judgy McJudgersons here, and we're going to judge what their mental status is there. So then we'll use ABPU. We're familiar with ABPU. A is alert. B is alert to verbal stimuli. Excuse me. P is being alert to painful stimuli, and U is unresponsive. This is a great, down and dirty, very quick way to judge somebody's mental status there. It's not the most accurate or precise assessment of somebody's mental status, because there can be things outside of that, right? If we're looking for A and O times 3, person, place, and time, you can even throw in that fourth, the events leading up to now. Somebody could have all of those, but still be altered. I think I've told you all the story about the lady that knew who she was, where she was, what was going on up until this moment, all that kind of stuff, when it was, everything. And then it took a while to realize that something was going on because she didn't remember where she lived. Same house for 30 plus years, and she couldn't remember how to get home in the town that she'd been living in for almost 4 decades. And so it took a while to get there. So while ABPU is great, it's not quite precise, and it may take some extra digging to get into and figure out, is there something wrong? Luckily, hopefully, we all have a good meter in our heads as to whether or not somebody is acting appropriately. So luckily, we're able to, or hopefully we can, realize when something is outside of the bounds of normal, and kind of follow up with that. So if your gut tells you, oh, something's just not right, this lady's just not acting right, this guy's just something's not right, then trust your gut and try to follow it up with some good questions about ABPU, where they've been, how they've been feeling, things like that. maybe we can get to the bottom of it. Children, baseline status can be difficult to obtain from them. They answer questions differently from adults. They feel pressures differently. Maybe they think they're going to get in trouble because we're there, and they're going to tell us what maybe their parents want us to hear. They think what their parents want us to hear, or they're telling us what they think, the kid themselves, what we want to hear. And so they're not the greatest reporters for their own health and things like that. There's a lot of other things that are going to influence their thinking, and so it can be difficult. And so talking to mom or dad, teachers, caretakers, anything else like that may help us get a better idea of what they're feeling or how they're acting. Again, as we said, so if we're talking about the secondary, if we move into the secondary assessment now, actually let's go back 1 second to the primary assessment. Anytime that you have an altered mental status here, as we're winding up our primary assessment, anytime that we do have an altered mental status, this is going to be a higher priority patient. Right? An altered mental status is very far from normal. And once we get into an altered mental status, things can deteriorate depending on the patient's underlying conditions. Things can deteriorate quickly. And so we want to make these folks higher priorities so we can get them to definitive care as quickly as possible. As far as the secondary assessment goes, again, what we're looking for here is underlying causes of the altered mental status, right? It's always a sign of something else. It's never the primary problem. The problem is something else, and it gives that patient an altered mental status. So a good body system exam, complete history, that could reveal information about why this person has an altered mental status. Again, this is where doing your detective work is going to pay off. This, your sample, your OPQRST, using good follow-up questions, right? This is where we're going to make our money in making a good assessment, right? This is the stuff that we can get paid for here. And so it's good to be comfortable to operate in OPQRST and sample and to be able to ask follow-up questions. And again, as we've been preaching, don't be afraid to ask follow-up questions. Maybe it's nothing, but maybe that question that you think is silly, it's going to lead you right to the problem. So let's don't be afraid to ask those follow-up questions. That good detective work there can oftentimes uncover the primary cause of the altered mental status. As we said, if we have family members or bystanders, things like that, let's interview them as well. Let's talk to them, and we can see, get a reading, an idea of how different is our patient now versus normal. What their baseline status, mental status is on a normal day versus today, that kind of thing. We can figure out how long things have been going on. Maybe they know the reason why somebody's like they are. So always good sources of information there. You want to review medications for them. The number one cause for adults, well, that's for seizures, but still it can be an altered mental status. Taking medications, taking new medications, incorrectly taking medications that they've been on, or stopping taking medications, going cold turkey rather than weaning yourself off of some. It could all produce altered mental statuses. So let's make sure that if they're on any new meds, if they're taking the meds correctly. Take a look for any of the medical alert jewelry, bracelets, the necklaces, that kind of thing. Maybe that'll give you an idea of why they have an altered mental status. Maybe it says diabetic on there, right? Maybe it says epilepsy on there, something like that. And that can give us an idea. Look for other health-related items for clues. Okay, do they have, do you see any medications around? Do you see like a glucometer around? Things like that. That can give you an idea of what's going on. So literally, as we've been saying all year, it's detective work. Sometimes when we're at their house, we can kind of like just take a look around the room, for things that might clue us into why they're altered. As we document this, we want to document what their baseline was here, and then we want to also document the changes that have occurred since we've gotten there. It's important to show whether it's been a good change or a bad change, right? Either way, it's got to be documented for us there. We'd like to use the Glasgow Coma Scale to provide more precise measurement of the patient's responses. We'll get more into the GCS scores, Glasgow Coma Scale scores. We'll get into trauma there, but this does provide a good measurement for us there. We have talked about that in class, and I got handouts for you as well on the GCS there. We don't need to know so much about it right now, but to start to become familiar with it now is a very good idea. All right, let's talk about diabetes and how that affects folks, what it is, how it affects folks, how it can give them an altered mental status, what our fixes for it are, what our assessment techniques, and all the good stuff here. So diabetes, here we come. All right, so one of the key things to know about diabetes is the importance of glucose. Glucose is a form of sugar. It's a simple form of sugar that our body uses as one of the building blocks to make ATP energy. It's simple for our bodies to break down. So we need a constant supply of it. And it's the basic source for our energy there. If we don't have it, the cells will die there. They need it. After sugars and carbohydrates are broken down and are converted to glucose, it is absorbed into the bloodstream, where the bloodstream then takes it out and takes it to the body, where all the cells can get nourishment from that glucose. There is an issue with glucose. So while it's easy to break down and use for the body, it's big. It's a big molecule, and so it's hard for it to pass into the cells without insulin. So insulin, as we know, is the hormone that's produced in the pancreas, and what you should think of it as is basically a key. It is a key that unlocks the cell, like unlocks a door to the cell so that large glucose molecule can pass into it. Without insulin, we can't get that glucose into the cells. Now, when we take somebody's measurement of their blood glucose levels, we'll see different numbers, and we'll get to what the ranges are here in a second. But inside the body, when the body recognizes that the glucose levels, the blood glucose levels, get above 90 milligrams per deciliter, that's how it's measured there, that the body's going to start producing or secreting the insulin there in order to help to get that sugar out of the bloodstream and into the cells where it's needed. Again, this is the process in which the insulin binds to the, or unlocks basically the door for the cell to get in. It binds to specific sites on the cell and allows for those glucose molecules to pass into the cell. Can't do it without the insulin though, so it's really important. The key is key. Anyways, normal glucose levels in the body, having normal glucose levels all the time is essential for maintaining those normal mental status levels. As soon as we start to get low on glucose, and we'll see again what the numbers are here in a second, but as soon as we start to get low, we're going to start seeing changes. And one of the first things we see with the patient is a change in their mental status. Here we go. We have the pancreas, which makes the insulin, secretes it into the bloodstream. The bloodstream transports it down to the cells where it binds to the receptor sites on the cells, and glucose can then enter. All right, so patients who are diabetic, those that have diabetes, there's a few reasons why they have problems getting glucose into the cells. They either don't produce insulin, they don't produce enough insulin for it to be effective. They've become resistant. They've built up a tolerance to their own insulin, and so it doesn't work as well anymore, and so they can't get as much because it's just not working as well in there. And we can also have other problems where the glucose that's made, the key is it's not the right shape, so it doesn't open those doors. So there's another problem there as well that people can have. In the pancreas, anatomically speaking, the islets of Langerhans is what produces the hormone insulin, and specifically they're called beta cells. So these beta cells in the islets of Langerhans, they produce the hormone insulin. Now, most cells outside of the brain use the insulin to transfer those large molecules across the cell membrane there. Brain cells don't often need it though. They're the one cells that don't need it. It's because they're so sensitive to its loss. They're actually not going to leave it there. But for the rest of the body, though, it's a necessary thing. Again, insulin's the key. It unlocks the cell for the glucose to enter. Now, we've talked about balance, right? Homeostasis, the Goldilocks zone, where everything's got to be just kind of right. Sugar intake and insulin levels need to be balanced out. Okay? And then if there's too much on one side versus the other, then we start to have problems. Okay? Too much insulin, not enough sugar, you get a problem. Not enough insulin, too much sugar, again, get more problems. So it's got to be in that Goldilocks zone, right? A nice zone where homeostasis is taking place, where we can be nice and good, everything's right. Levels matter, right? All right, so let's talk about diabetes. Diabetes mellitus, that's the technical term, the medical term for it. And it is the result of an underproduction of insulin, or the inability of the cells to use the insulin properly. So maybe properly, that is. So maybe the insulin is misshapen. Maybe the patient has built up a resistance to their own insulin, so it just doesn't work right. Any number of those things can cause this problem. So there's two types of diabetes that we're going to talk about. There's type 1, it's formerly known as insulin dependent diabetes. What happens here with type 1 is the pancreatic cells, they're not functioning properly. Oftentimes this type of diabetes comes on in childhood. Oftentimes it's referred to as juvenile diabetes. This is when it comes into play. So one of the problems here with type 1 diabetes is that the patient's own immune system will see the beta cells, the cells in the islets of Langerhans that are actually producing insulin. They'll see those as foreign invaders, and the immune system will attack them. So either destroying them all completely, so there's no insulin that's made, or damaging them so that there's not enough insulin that's made, or that it's not being made properly. So the result is there's too little insulin circulating in the bloodstream to get the transfer to happen from the glucose from the bloodstream to the cells, and that's the problem. And so these people were insulin dependent. They would have to take insulin because the body's not producing enough or any at all for it to happen. A lot of these folks get synthetic insulin. That's coming out. That's out and about now on the markets. We also get it from other places as well. There's also type 2 diabetes. These are non-insulin dependent people. This is acquired. This is normally an acquired disease, meaning that you get it at some point in life. Right? So most of the people that get these are adults, and it's because of lifestyle choices. For the most part, the body's not using insulin properly any longer. The patient has um, formed a resistance to it. They've gotten used to it. They have a higher tolerance, basically, for it. Pancreas, it's secreting enough insulin, but the body's just used to it. And so these are people that are, they've got high loads of sugar in their bloodstream, and they're doing it for, years, basically. It takes a long time to become, to build up this tolerance or this resistance to it. So it takes years to get there, and that's why we get it as adults, and not off the bat as kids from just eating, eating or drinking an unhealthy or a high in sugar diet, rather. So not necessarily totally unhealthy, but at least high in sugar diet. So the body's, it's just not able to use it anymore. So a lot of these folks that get type 2 diabetes, they can control it through medications that they get, diet, and exercise. And a lot of times when these patients are diagnosed here and they make these specific lifestyle changes, what they eat, how they exercise and burn off, the sugar, things like that, that they can be completely done with it. Their body will recover from it, and they can get off of their meds and things like that, but they're still going to have to control it through diet. So type 2 you can acquire and kind of get rid of there. But type 1, once you have it, you have it. That's a chronic disease, lifelong. All right, some specific things to know about diabetic emergencies. The most common one that you are going to see is hypoglycemia, and that is an emergency for a diabetic patient when they are low on blood sugar. So hypoglycemia, it's low blood sugar there. It's caused by a person taking too much insulin. So if they eat a meal, but they take, let's say, double their insulin shot, then that insulin takes care of all of that sugar, gets it into the cells, and then there's nothing left. It's all been used up too quickly. Cells use it up, and then there's nothing left in reserve. So too much insulin, not enough sugar intake. So basically, not eating. This right here, the too little sugar intake. Understanding this is important because one of the most important questions that we can ask of a diabetic patient is, when was the last time that you ate? If it's around lunchtime or something like that, and they're saying, I haven't eaten since it's been a busy day, or I haven't eaten since last night, since dinner time last night. That could be way too long of a period for somebody to not bring in sugar in order to keep all of the cells running at an optimum level. So too little sugar intake, over-exercising or over-exertion, every time that you move a muscle, every time that you do something, the body's burning off some of this sugar. So if somebody is over-exercising, well, they may burn through their stores, and then all of a sudden, there's nothing left there in the bloodstream to nourish the cells. Vomiting, we can produce low blood sugar. As we remember, things get absorbed into the body in the small intestine for the vast majority of nutrients, like sugars. And so if somebody vomits, they're not able to absorb the sugars. The body hasn't had the opportunity to. It's all been ejected, right? So they can eat something, but if they throw it up, they're not getting the benefits of that food getting past the stomach into the small intestines. An increased metabolic rate. This is what this means is something's going on in the body that's causing the cells to work extra hard. And one of the things that can do that is having a fever. So when somebody has a fever, they run through more blood sugar as the body is fighting whatever invader, infection, whatever it might be, whatever sickness is causing the fever. As their body's fighting that, it causes them to go through and use much more blood sugar. So an increased metabolic rate, fever being an example of something like that. So when the blood sugar is reduced, the brain and body cells, they start to starve. And brain cells in particular are much, much more sensitive than other body cells in the loss of sugar here. Now, all body cells are sensitive to it, but the brain, we're starting to see the effects very early on what can happen. The other type of diabetic emergency we'll see is hypoglycemia. So, excuse me, we're still on hypoglycemia. Still working on that. Hypoglycemia, it leads to altered mental statuses. It's a quick downward slope. So we can start with an altered mental status. Maybe we go to unconsciousness, unresponsiveness. We can get seizures, coma, brain damage, and even death. So it's a slippery slope. Once we start getting low on sugar, things just get worse the lower they get. Always, you get low, the patient gets bad. It's a bad thing, right? All right, so for hypoglycemia, one of the key indicators for us to figure out in the field is how quickly these symptoms, these signs and symptoms have come on to the patient. It's not uncommon for a bystander, like a coworker, family member, something like that, to say about a diabetic patient, I saw them normal like 20 minutes ago. Everything seemed fine, but now they're really altered. So the onset of hypoglycemia is very quick. It's rapid. Signs of this will include the abnormal behavior, the altered mental status, and they can kind of mimic drunken behavior. So it's not uncommon to hear stories about diabetics, especially before there was training on police force about diabetes and things like that. It's not unusual for people to be arrested for like drunk driving or things like that when they're in fact having an altered mental status, a diabetic emergency. And so you can search it. There are cases where people have died in jail and in the drunk tank being held overnight on the suspicion of drunk driving when in fact it was a diabetic emergency. So they can mimic a drunken stupor. They can look and act drunk when in fact there may be no alcohol whatsoever in their system. Here's another hallmark. This is a textbook classic sign or symptom for somebody that is suffering a hypoglycemic episode. Pale, sweaty skin. Right? They're going to be pale, cool, and diaphoretic. When you get out in the field and you see one for real, and you're like, oh, that's pale, cool, and diaphoretic right there. It is exactly what you would imagine it to be, how these people look. So pale, cool, and diaphoretic. They'll be a bit tachycardic. The body's trying to combat this by enacting its fight or flight response. And so we're going to get a higher heart rate, and we're also going to get a higher respiratory rate as well. They're classic signs of the fight or flight response, right? High heart rate, high breathing rate. We're going to get sweating too. But so these are all classic signs here. So the altered mental status, pale, cool, sweaty skin, tachycardia, and rapid breathing, tachypnea. We can also see seizures here. Hypoglycemia can affect the brain cells so badly that a patient goes altered, unconscious, and then can have seizures as well. So also a bad sign for them. Which means for us, let's take this for just a second. Anytime that somebody has a seizure, one of the things that we absolutely have to do is check their blood sugar. Absolutely have to do that. It may not be epilepsy. It may not be medications or something that could be low blood sugar. So we absolutely have to check for low blood sugar whenever we see seizures happening with our patients. All right, so when we have a hypoglycemic patient, our goal is to get sugar into the body as quickly as we can. That's our treatment here, our big treatment plan. It may include a couple other things, but our main goal is to get sugar into the body so that the cells can utilize it properly. For us as EMTs, we use the oral glucose, and so we know we have to keep in mind the indications, the contraindications for these things. Contraindications that we most need to keep in mind for oral glucose is whether or not the patient has the ability to protect their own airway. So we can't give it to somebody that's unconscious. They have to be able to swallow, because if we're putting this tube of gel basically into their throat or into their mouth, as they can't swallow it, now we have an airway obstruction. Now we have the possibility of the patient aspirating the glucose, and that's not a good thing, getting that stuff down in your lungs. You don't want anything but air down in your lungs, you know. So oral glucose, we need to know how to use that, and that's the tool that we're going to use most often. All right, so the cells of the RAS, which we mentioned earlier, reticular activating system, they're very sensitive to a loss of oxygen, glucose, and water. And so we need to get that glucose into the brain. So if the RAS, which is in charge of us being with it, conscious, awake, paying attention to our surroundings, being kind of in the moment, things like that, well, once that starts operating weird, then we start getting those altered mental statuses, the unconsciousness, the comas, that kind of thing. So we need to get that sugar up into the brain. All right. Second type of diabetic emergency we're going to come across, and we're going to come across this less often, is hyperglycemia, and that's high blood sugar. It's caused by an insulin deficiency. The body's not able to produce it correctly. Maybe they don't produce it at all. Maybe what is produced is not enough. Maybe it's misshapen, so the key doesn't fit into the lock there. Maybe somebody's not taking their insulin really well. But basically what's happening is when there's hypoglycemia, there's not enough sugar around for whatever reason. There's not enough sugar in the bloodstream. And so because of that, it's not getting into the cells. Here the problem is there's a lot of sugar. There's a ton of sugar, but it can't get from the bloodstream to the cells. So that's the problem. There's plenty of sugar here. And in fact, when we'll take a look at numbers here in just a minute, you'll see that, whoa, there's a ton of sugar here still in the bloodstream. It's just not getting into the cells. That's where the issue is for hyperglycemia. Lots of things can be factors here. Infections, stress, increased dietary intake, they're all factors here. They're all factors. Now, here's the key. Right? We say with hypoglycemia, the onset of symptoms and things like that are rapid, sudden. Okay? Hyperglycemia is more of a chronic condition where it develops over a long period of time, days and weeks, right? Even longer than that in some cases, right? Days, weeks, maybe even months. You're just climbing steadily there. Signs of this for this are going to include chronic thirst and hunger. This is the body's way of saying, like, hey, we're not getting this stuff down into our cells. So the patient's going to feel chronically thirsty, chronically hungry. They can't get enough in. The body's desperately trying to get sugar in any way that it can. The two ways that it does is drinking and eating. And so the patient's going to feel chronically thirsty and hungry. All that sugar is getting into the bloodstream, though, it's just not getting to the cells, and so it's not going to satiate the patient. We're going to have increased urination, polyuria. What that means, the body's recognizing its blood glucose levels. It's seeing that there is a lot of sugar in the bloodstream, and it recognizes that it is not good for you. And so it tries to offload it. And one of the ways that it does is through urination. And so if you think about it, if somebody's peeing a lot, right, this polyuria, trying to get it out of the body, this is going to affect our water levels too. And so they can very rapidly become dehydrated. So we'll see signs and symptoms of dehydration with these folks too, because of the increased urination. One of the things that we're going to see with the increased urination is we're going to see a change in color. So we've talked about it before, what healthy urine looks like versus what unhealthy urine looks like. And so these folks are going to be becoming increasingly dehydrated, which is going to make the urine itself darker. But it's also going to be loaded up with sugar, basically, and so that's going to change the color too. So their urine is going to be very dark. And so one of the questions you can actually ask is, how has your pee look the last few days? Right? At least the last few days. Have you noticed the color of your urine? What does that look like? There, and that can be a good sign of what's going on in the body for us, right? Some of that detective work, some of those follow-up questions that we might be able to have for patients when we're doing our secondary assessment. Nausea is another sign or symptom that we can see here as well. We talked about the dehydration and what causes that. All right, so the cells are slowly starving here because not enough glucose is getting in. Maybe we're getting a little bit in there, and so that's why we're still alive. It's not as sudden an onset as as hypoglycemia there. But they're slowly starving for that glucose. All right, so the body starts to burn fats and proteins, and because it's not burning any sugar, right? And because of this, it doesn't burn as clean. It's not as efficient. It's harder for the body to get this done than it is to burn glucose. And so when it does that, it produces excessive waste products in there. And over time, that can lead to what's called DKA, or diabetic ketoacidosis. This is a potentially fatal condition for hyperglycemic patients. And so while we don't see it as often, it is absolutely important to know what it is and how to recognize it. Because again, it can be potentially fatal. Signs include a profoundly altered mental status. These people are very altered. This is kind of your drunken stupor kind of thing. Again, it is not uncommon. More police agencies are having training on this kind of thing. But it is not uncommon for somebody with DKA to be like pulled over and be thought of as drunk. And they get arrested, go to jail, and all that kind of stuff. And then they wind up in a really bad place, dead, after not getting some treatment. It has happened. It can absolutely happen again. So they'll have that profoundly altered mental status. They'll be acting kind of drunk. There could be signs and symptoms of shock because of profound dehydration, right? That they are peeing all the time. They're getting rid of all that water, right? And maybe that excessive thirst, maybe they're not drinking enough to replenish the water that they're pushing out here. So we can see the signs and symptoms of shock as well. We're going to see rapid breathing here, and we're also going to see we'll see that in a second, but we'll see some rapid breathing here for them as well. Now, one of the things that the body does, along with trying to pee out some of this extra sugar, we're actually going to kind of breathe some of it out too. We talked about this in class, but one of the ways that the body, that a lot of people don't realize, one of the ways that the body gets rid of things is by exhaling it out. So they're going to be exhaling, trying to exhale some of this sugar out of them. And so they get this acetone odor on the breath. Another way to put this is their breath smells really fruity. It smells kind of alcohol-y and fruity there. So if you see somebody, you can see why police might get this wrong. They're profoundly altered, right? Acting really drunk, and then their breath smells kind of alcohol-y, fruity. It's really easy to be like, nah, man, I can smell it. You must be drinking wine or something that was going on there. And the way you're acting, these people would never pass what do they call it? I'm blanking. A sobriety test on the side of the road. They would never pass one of these things. And so you can see how easy it is to confuse the two. All right? So that in and of itself, if you have to prevent this from slipping by us and not catching us, anytime that we have somebody that is having a medical emergency or even a traumatic emergency, if they're acting kind of drunk like this, check their blood sugar. Check their blood sugar. Maybe they're not drunk. Maybe they're diabetic and they are suffering diabetic ketoacidosis at the moment. It takes a minute to check somebody's blood sugar. It's so easy to do. Never write somebody off. Don't be myopic and tunnel vision and be like, this guy's just drunk, right? It's going to stink to have to explain why you didn't do a blood sugar test on somebody that happened to die in police custody, because you're like, they're just drunk, right? So anytime that you have somebody that is acting drunk, right? We just went over hypo and hyperglycemia, and both of them have symptoms where somebody could be acting drunk. So why not? Why not? Anytime that you think alcohol may be involved there, get a blood sugar reading. All right, so we want to ensure scene safety here for our patient assessment. As we said earlier, altered mental status, folks with an altered mental status can be a bit combative. So make sure that you're safe. The patient could get agitated, they can be combative, maybe even get a little violent. So if the first instant it even crosses your mind where you're like, you know what, maybe I'm not safe here, call law enforcement. It's as simple as that. If you're not feeling safe in the moment, right, back out of the house, get in the ambulance, get yourself out of a position where something untoward could happen to you. We don't want that happening, right? Protect yourself at all times there. All right, performing the primary assessment, identify the altered mental status with our AVPU, right? Introduce yourself, ask what's going on. You're probably going to be able to tell that something is not right here. Make sure that we get a good ABC when we're going through our primary assessments, right? These are going to be profoundly altered people, or they can be. So we got to make sure that airway open. Is it going to stay open with this profoundly altered mental status? How's their breathing? Is it adequate or is it inadequate? Right? We know that they're going to be breathing rapidly. So is it enough to keep them alive? Right? Do we have to do things like ventilate or give oxygen? Are they looking do they have signs and symptoms of shock? Do we have to start treating for shock, right? High flow O2, lay them down, give them cover with a blanket, get them to the hospital. It's a treatment for any kind of shock is that right there, your basic treatment. All right, performing the secondary assessment, try to get a good history. You may not be able to get it from the patient, so bystanders, take that blood glucose level, get that taken in your secondary assessment there as well. Get a history of the patient's present episode. When did it start? When did it start? How long has it been going on? Is going to give you your best idea here about whether it's hypo or hyperglycemic when we're talking about in regards to getting the history. How long has this been going on? Has this been going on for a while and slowly gotten worse? Or was it like, I don't know, Jerry was fine like 10 minutes ago. I just saw him in the break room. But now he's like this? That rapid onset should cue you right away into hypoglycemia, low blood sugar there rather than high. So when did this start? How long has this been going on? That'll give you really good ideas as to narrowing down your differential diagnosis. All right, this might be diabetes. Is it hypo or hyper? These are kind of some of the questions where you can figure that out. Identify any associated symptoms that they may be feeling that can kind of get us further clued into what's going on here. Any altered mental status, we want to make sure that we haven't had any injuries to the noggin up there, or melons. And then ask if there's been anything that has increased the metabolic rate of the patient. Have they had fevers? Have they had seizures? All right, get a really good sample history as best that you can. Hopefully bystanders there are going to be able to provide it, should the patient be too altered too. Look for medical ID cards, wallets, there could be a card in there, that kind of thing, in their purse. Maybe they have medications with them so we can note any of that. If you're home, if they're home or if they're out and about, maybe they got a bag with them. I know a few diabetics, and they don't go anywhere without their glucose meter. They don't go anywhere without that. They have it with them at all times. You walk out of the house, you're like, all right, got my wallet, got my keys, got my phone, right? And then you're good to go. These folks are like, I got my wallet, got my keys, got my phone, I got my glucometer. They have it with them all the time. They have to. They have to. So check for that. That's usually a good indicator that a patient's got diabetic problems if they've got a glucometer at home or with them. Look for implanted insulin pumps. These are often little devices about yay big. They are worn on like a belt, and they'll have a small spot. It kind of looks like a sticker with a little tiny tube going to it. It can be on their leg, it can be on their abdomen, something like that. So look for an implanted insulin pump there. When you're doing your secondary assessment, one of the tests that we're going to do is we're going to use that glucometer. We're going to get that blood glucose reading done there. Right? Luckily, our local protocols permit EMTs to do this. All right, so when we're doing our assessment, we need to make sure that patient's alert enough to swallow so they can protect their own airway. A good way to do that is tell them to swallow their own spit. And just, hey, can you just swallow whatever you got in your mouth? Swallow your spit there for me, and just watch them. Are they going to choke on a little bit of spit? Do they have trouble handling that? If they have any troubles handling that, they're probably not going to be able to do so hot taking the oral glucose. Obviously, with everybody, we get a baseline vital signs. With either hypo or hyperglycemic patients, we're going to see things. We should expect some things with their vital signs: increased heart rate, increased respiratory rate for 2. Signs and symptoms, sites and symptoms, that too. Look for those diabetic emergency. Again, hypoglycemia, which we'll see the most of. Rapid onset, right? Like I said, hey, Sally was doing awesome just a couple minutes ago. Now she's altered. She's not with her, but not sure what's going on. Rapid onset, altered mental status, intoxicated appearance, and this one is for hypoglycemia. Pale, cool, and diaphoretic skin. It is textbook for that when you see it. Then we're going to see the elevated heart rate. Could see hunger. Could see excessive hunger, excessive thirst, excessive urination, all those kind of things. Uncharacteristic behavior, all right? This kind of goes along with the altered mental status, right? Maybe they're highly anxious, maybe they're combative, maybe they're argumentative, it may be highly unusual for them. They could be having seizures, other altered mental statuses like being unconscious, being unresponsive, in a coma, things like that. Now, here's my thing here, right, with our assessment. Hopefully we can hone in on it and say, this is hypoglycemia. This is what it is. The signs and symptoms fit, history makes it fit, all that kind of stuff. All right, and then we can administer oral glucose after we figure out that they can, in fact, protect their own airway and swallow safely. Here's the thing, and I think there's another. There's another thing here coming here, but here's the important thing to remember. If for some reason there's no bystanders, you can't get a history, and the patient is not able to communicate with you well, where you're confident at all in their history, but you're confident you've got a diabetic thing going on here. I'm not sure if it's hypo or hyperglycemia. If they're having a diabetic emergency, they can protect their airway, give them the glucose. It will not hurt a hyperglycemic patient. It won't hurt them. They'll be fine if they get even though their blood sugar is really high, it's not going to hurt them. A hypoglycemic patient, though, it can save them. It can make all the difference in the world. And so if you're unsure, if you freeze out in the field, you're not sure, like, I don't know what the difference is anymore. It's been such a long time. Whatever it might be, if you're uncertain, give them the glucose. All right. Again, it will not hurt the hyperglycemic patient, but it will absolutely help the hypoglycemic patient. Okay. So if you're, it's important to determine what we're working with, hypo or hyper. But if you can't, right, just give that glucose as long as the patient isn't having any contraindications. All right, let's talk about those meters here real quick. They make it possible for patients to test their blood glucose levels every day. And most diabetics will check it multiple times a day. So multiple times a day, every day, they're sticking their fingers there for that. It helps them know how much insulin to take, and when, and how much to eat as well. It helps regular testing at home by the patient, helps them to avoid diabetic emergency-related complications. None of these, the vast majority of people who I have treated that are hypoglycemic have been in that position before, and especially the ones that are really altered, and they kind of come about and they're like, oh man, did it happen again? I'm so sorry for you guys having to come out again to help me, that kind of stuff. Sometimes they're embarrassed that, you know, they didn't keep up with their own upkeep with their diabetes there, things like that. So, you know, regular testing, staying on top of this disease, and it's insidious. These diabetics, they have to be on top of it every single day. Every time they eat, every single day, they have to be on top of it. So failing to test obviously can really lead to complications with it. There are things called continuous glucose monitors, glucometers there. What it is it's a little thing that can basically stick in their skin, and I think some you can test it on demand. I think others test just regularly, and it works with like an app on your phone, and you can every few minutes it just checks your blood sugar, and so they can be right on top of it. So these technology is helping, and it's advancing these things as well. We shouldn't use a patient's glucometer. Let's just use our own. Maybe theirs isn't calibrating correctly or things like that. So let's use our own if we have them. If you happen to be working in a place that does not allow EMTs to use glucometers, it's not uncommon for EMTs to say, hey, sir, would you mind checking your wife's blood sugar with your glucometer? You know, ma'am, can you check your son's blood sugar for us using your monitor? That's not uncommon. When I first started coming up where I was riding, we weren't allowed to. We had to call medics in to get that. And so obviously that can be a logistics problem there. And so if they have the glucometer there at home, they can use it. They know how to use it. So they can use that too, and you can go off of what the reading says. Here's just a typical picture of a glucometer. We have the monitor itself. We've got some alcohol wipes. We've got these orange things over in the right-hand side in the pocket over there. Those are the lancets, the little needles that will poke the skin. And we've also got in this little film canister looking deal. You guys probably don't even know what a film canister is. It's showing my age. We have the test strips. Those are what the blood actually goes on. And, it sends the readings there into the monitor. There for your results. All right, blood glucose measurement. Let's talk about this. When a patient is less than 60, we got to know these numbers. When a patient's less than 60, they'll start getting symptomatic. In our area here, and again, maybe different in other areas, they may have different regulations there, different protocols. In our area, we start treating at 59. Anybody that is below a 60, we start treating there. Less than 50, you're going to start to see significant alterations in their mental status. You can even get unconsciousness. Now, some people are different. I've had people that have been unconscious at like 45. I've had people that are not unconscious at 25. They're completely not with it mentally. I've told you guys the story. It's a 70-year-old man who's naked on his bathroom floor, and when you talk to him, the only response that you got out of him was, ah! That was it. That was it. He was incredibly low at 25. So once you're down around 50, start to expect bigger signs and symptoms. Okay. Greater than 140 indicates hyperglycemia, that we've got too much in there. As we said earlier, when the body hits around 90, it starts pumping the insulin in, and so it starts taking care of that. Now, context here matters. Context matters because if you eat a nice big fat meal, and then just a little while later go ahead and check your blood sugar, well, your body's processing that and dumping all the glucose into your bloodstream. Well, it's going to get high. It's going to spike for a little bit. So you can eat a big fat meal and check your blood sugar. Maybe you're up at like 180, maybe you're at like 200, something like that, right? But then just a little while later, you're coming back down. The body's starting to handle this new load of sugar that it's gotten and get back down into normal levels. So context does matter a bit with these higher levels. Greater than, we're getting up into numbers like 200, 300, 400. Greater than 300 is where we're going to start seeing the body do things like recognize it's got too much sugar in there, and it's going to start with the polyuria, the excessive urination. So it's going to start peeing to get some of that stuff out, and so we'll see signs of significant dehydration there and other symptoms as well. Now, this goes for all of our electronic equipment, right? Whether it's the heart monitor, whether it's the pulse ox, or the blood glucometer, always question a reading that doesn't match up with what is sitting in front of you, your patient. Trust your gut. If you got somebody that's profoundly altered and is a diabetic, but they're showing it, their blood glucose reading is 100, something doesn't match up. So take it again. Take the reading again. Maybe we didn't get a good one the first time. Maybe the test strip was bad. Maybe that monitor is not calibrated correctly. Things like that. So if you're getting a reading that's, weird, then question it. Like if you put on pulse ox on somebody and it says their heart rate is 200, but you can clearly feel it at 70, you're clearly feeling it. Like, wouldn't you be like, well, that doesn't seem right? I can feel this, and it's obviously not that fast. So, while all of our tools, all these electronic tools that we have can be fantastic, they're not foolproof. They're not foolproof. So trust your gut. If you get a weird reading, trust your gut, and in that it is weird, maybe test again and see what can happen now. So there's a couple of examples why it might not be good. Meter test strips might be bad, not enough blood, meter's out of calibration, maybe it wasn't properly used, right? Human error in using it. So again, trust your gut. So glucometers can only measure so high, and they can only measure so low. Their sensitivity levels vary a bit, but a reading of high, it will actually say high on there, H-I-G-H, or I know old monitors that we used to do would just say H-I, high, but that would be over certain levels. So maybe they're all up at 500 or above where it says high, but I know there at least used to be monitors out there, and maybe they still are, that they would be high over 300. You have some here that mark high as being over 400. So you gotta kind of know where your monitor is, but know this: if you get a high reading off of a patient, and the reading is good, you believe it to be accurate there, they've got way too much blood sugar in. They've got way too much blood sugar in. It's probably enough to be like, all right, it's at least over 300, but you should know what your monitor will display. I'll take any of the questions out of it. Usually anything below 15, which is unbelievably low. Usually something under 15 will read as low. All right, for patient care, a lot of times, if it's very mild hypoglycemia, very mild minor altered mental statuses, you might be able to just get a little glucose in them, and they might be all right. That might be it. It's not uncommon for providers to give somebody a little sugar and then go in the kitchen and make them a peanut butter and jelly sandwich. Peanut butter and jelly is great. Bread is sugar. Jelly, sugar. Peanut butter, sugar. So it's great for them. We can get them back to a normal status there by giving them some glucose, and then by eating that sandwich, giving them some juice to drink, something else like that. We know they're going to be good for at least several hours, and they'll probably come around and make sure they're taking their own glucometer readings there. Now, we know what the criteria for administering oral glucose are. They're diabetic, they have an altered mental status, they're awake enough to swallow. If they meet the criteria, give it to them. You know, they can squeeze their own tube, or if they can't for whatever reason, but they can still swallow, then get it in there. You might even put it on a tongue depressor and then put it in buccally, right around here between the cheeks and the gums. They can kind of rub that in a little bit, access some of the vasculature that is in the gums around there. That can help as well. Get that sugar right into the bloodstream. After we administer this, we want to reassess the patient just like with any of our interventions, right? Whether it's just oxygen or if we're doing aspirin and nitroglycerin or whatever it may be, we want to reevaluate them. We're going to reassess them. Are they mentating better? Are they acting better? Are they do they know what's going on? Are they coming out of whatever it is? If we don't have an improvement there, then we can consult medical direction. Hopefully at this point, maybe we're already loaded and on our way to the hospital as it is. If the patient is unable to swallow, then we got to treat them as any other patient with an altered mental status, right? So we got to protect their airway. We got to make sure that their ABCs are all good, we're oxygenating well, and then get them to the hospital. Maybe you call for ALS, right? If they're unconscious, if they're unresponsive, and you're riding on just a BLS unit, right? Basic life support, just EMTs on there, and we're not able to do things like get an IV, then we need to get ALS there so they can establish intravenous access, and then give them some of their drugs that they can get, namely D50 is what they are normally going to get. It's called dextrose. All right, so secure the airway, provide ventilations if needed, perform CPR if needed if they're getting worse, right? If they code on you, and then get them in the recovery position. If you don't have some nausea, some vomiting, some things like that, just in case. So request ALS to meet up like we said if they're not there already. All right, in the patient care, the most important thing here is can they swallow? If they can swallow, let's give it to them. If they can't, then let's roll. Let's get out of here. Let's get to definitive care at the hospital. All right. We don't want to be putting things in a patient's mouth or their airway that can become an obstruction, or that they could aspirate. Right. We can't do that. We can't do that. So again, they need the sugar, but if we can't protect the airway, then it's not appropriate. That just brings up much bigger problems, and like a lack of oxygen because of an obstructed airway is just going to make our problems much worse. So let's not block that airway off, right? All right, let's compare these two. Compare a little. Here are the signs and symptoms of hypoglycemia versus hyperglycemia. All right, so some differences here. The onset, as we talked about, with hyperglycemia, it's a slow onset, very slow. Hypoglycemia, though, tends to happen very quickly, come on suddenly. The skin, this is another big indicator. As we've always talked about, the skin is just like this billboard that lets us know something's going on inside. So hyperglycemic patients, they'll be warm, red, and dry. Hypoglycemic patients, on the other hand, they're going to be pale, cool, and diaphoretic. They'll have that cold and clammy skin. Pale, cool, and diaphoretic. When you see a real hypoglycemic patient, it is textbook pale, cool, and diaphoretic when they are. The breath, hyperglycemics will have that acetone breath, that fruity kind of alcohol-y smell there, and there's nothing really to go along with hypoglycemics, nothing specific there. So somebody taught me a long time ago, if you can't tell the difference, so I got to know sweat. If they're sweaty, it's hypoglycemia, right? But with these things combined, like rapid onset, pale, cool, and diaphoretic there, there's an altered mental status and that kind of stuff, then it should point us directly to hypoglycemia. Again, as we talked about with some of the signs there, hyperglycemic patients, they may be breathing very deeply. They are going to be incredibly hungry and thirsty. They may have abdominal pain. They could be nauseous and vomiting, and frequent need to urinate as well. Again, as we talked about, if for some reason you cannot distinguish between the two, it's not that important. What is important is that you take action. We can give oral glucose to anybody with a diabetic emergency. It is not going to hurt hyperglycemic patients, but it will help hypoglycemic patients. So there's nothing there other than protecting the airway that we need to be concerned about. If you can't tell, it's okay. If we know it's a diabetic emergency, or we think it is, but we don't know hypo versus hyper, it will not hurt hyperglycemic patients. Hyperglycemic patients won't hurt them, but it will absolutely help a hypoglycemic patient. All right, let's talk about a few other causes of altered mental statuses. All right, so let's talk about seizures here. Seizures could be caused by a number of things. So if the brain's normal functions are upset by injury, infection, diseases, loss of blood sugar, the brain's electrical activity can become impaired and irregular. And when that happens, we can have sudden changes in sensation, behavior, like consciousness versus unconsciousness, those kind of things. And something called a seizure, which I think we're going to be all familiar with, at least generally. There's partial seizures, and they may affect only one part of the brain. And then it could involve one part of the brain, and you may get uncontrolled convulsions in a patient, and they could be fully alert. Sometimes they may lose consciousness without the convulsions, so you can have both there. And then we have generalized seizures. They affect the entire brain, and it does affect the consciousness of the patient. When there's a generalized seizure, they're going to be unconscious, and they're going to get the convulsions, the shaking, all of that. Everything that you think of when you think seizure, that's what they're doing. What we're called most often for is called a generalized seizure, or specifically a tonic-clonic seizure. It is the hallmarks of tonic-clonic seizure are unconsciousness and major motor activity. And what they mean by that is the convulsions, all the convulsions that could be happening. Oftentimes it comes on very suddenly and there's no warning. Sometimes it does come on still very suddenly, but they may have a little bit of a warning. We'll talk about what that is here in a second. When they do have these convulsions, the body they're thrashing about wildly. It is uncontrolled, irregular body movements. The whole body is shaking. And once you see one for real, you'll see how disorganized the movement is. And because of how disorganized it is, it's actually really hard to fake one of these if you know what you're looking at. It can be hard to fake one. Um, Now, the tonic-clonic seizures, they've got three phases. The first phase is the tonic phase, where up to about 30 seconds, the body's going to be just completely rigid. All the muscles tense. All of them are really tense, right? So they're not going to be, they're like locked up. So breathing here may stop, because when we say all the muscles, we mean all the muscles. So all the intercostal muscles, the diaphragm, all all the muscles that support our work of breathing, well, they may not be able to do their job, so breathing may stop. They may lose control of their bladder and bowels, and so they may urinate or defecate themselves. That's the tonic phase. In the clonic phase, this is when the shaking starts, right? The body is jerking violently. It's a highly disorganized, random shaking and jerking and convulsing there. It can last for it's usually just a minute or so, but it can last for a very long period of time, 10 minutes, right? We may see the patient foaming at the mouth as well. Now, breathing here in this phase, it's probably not happening to a level that we would call adequate. And so you're going to see them become pale. They may get cyanotic even, so that bluish gray color that we talked about there. And then after they're done seizing, they enter the recovery phase. And the recovery phase is called the postictal phase. Postictal phase. The convulsions have stopped. Consciousness is regained. Now, it's not always right away. Convulsions stop and they wake up. It's not like that. It may take them a minute or two or five, or sometimes longer, to actually come out of it, depending on how big, how long, how bad the seizure was. But this is the phase where they regain their consciousness. They can be drowsy. They can be obviously altered. They can be combative. They can even be violent. Basically, the brain is not working correctly here. There was a hard reset on the brain, and the systems are basically in this postictal phase. If you're comparing like the brain and the person to a computer, the brain just reset. Now all the systems are starting to come back online. They're gaining consciousness. Breathing starts to become right. You start seeing the color come back to them, that kind of stuff. But part of the mental status that is coming back is they may be really drowsy. They may be really tired. They may want to go to sleep. They may be violent. They may be confrontational. They may be not willing to work with us in helping take care of them. So be alert for that. Now, as I said, a lot of these seizures can come on without warning, but sometimes they are preceded by what's called an aura. This can be a smell or a sound, a general feeling that somebody has. So maybe when you're talking to a patient that's had a seizure and you ask about it, it's like, you know what? Like right before it happened, I could smell like freshly cut grass or pennies. I could smell pennies or something. I could smell something burning, whatever it may be. You might be able to have that, and that's called an aura. That's not uncommon. For adults, the most common cause of seizures is not taking prescribed anti-seizure medication. As you get out there more and more, and you're riding and you're working with patients, you're going to realize that a lot of people don't take their medicines correctly. And when you are on anti-seizure medications and you stop taking them, seizures happen. So one of the most common causes for adults is for them to not take their medication. The most common cause for seizures in infants and young children, about 6 months or so to 3 years old, is high fever, and that's called a febrile seizure. Febrile is F-E-B-R-I-L-E, febrile seizure. And it means that its origin was the fever. These fevers, it's not that they got really high that caused it, it's that they spiked very quickly, and this causes like the disruption. So that patient, that kid goes from 101 to 103, like that, right? That's a really bad fever. that high. So it's the spiking of fever that you'll see. It's not having a fever. The fever spikes to a high level quickly. Some other causes, we can get hypoxia, stroke, hypoglycemia is one, traumatic brain injury can put somebody into seizures as well. So we're altering the brain's electrical activity through lack of oxygen, traumatic damage, things like that. Toxins, drugs, chemicals, hypoglycemia, like we said, all these can be causes of seizures, brain tumors, congenital birth defects. So these are people that are born with problems with their brain. It's genetic is the cause there. Again, infection as well, and metabolic. That's the fever. And idiopathic means just kind of it's not a great explanation for it, basically. More causes: epilepsy, measles, mumps, other diseases, eclampsia. We'll talk more about that when we talk about pregnancy. Heat stroke can bring it on. The onset of syncope. We know syncope means passing out, so it could just be the beginning of that. Something to keep in mind: epilepsy is an umbrella term, and it's used to describe like seizures are difficult for doctors to diagnose of what the root cause is. And so if somebody's having multiple seizures, they can kind of put it under this blanket term by just saying they have epilepsy. But it's basically, if somebody has epilepsy, it means they're having seizures and that it responds to medication. Okay, so if somebody's epileptic, they may not know the root cause of it, but they do know that, yes, the patient does have seizures, and yes, that condition reacts positively to medication. They can control it with medication. It can be, you can have them at birth, or you can acquire these as well. Medications are great for these folks, and they just have to stay on top of it, really. So when we're doing our assessment, we try our best, as always, with any condition, to try to describe what had happened in the moments leading up to, the moments during, and the moments after the patient has had that seizure. So some few questions that we can ask of bystanders, because we're probably not going to be able to get much from the patient, especially if they're early in their postictal phase. What were they doing before it started? Did they have an aura? Did they say something like, did they say anything about smelling something weird or hearing anything? Anything strange that they may have mentioned? What did they do during the seizure? Were they on the ground flopping like a fish? Were they just rigid and staring off into space? Did they lose consciousness? Were they breathing? What kind of stuff there? Was there a loss of bladder or bowel control? How long did it last? Is a great one. You need to know how long it lasts. How many were there? Did they have a seizure, stop seizing, not regain consciousness, and then start seizing again? Those questions are really good. And then after they stopped seizing, what happened then? Right, so we need to know the before it happened, what happened during, and what happened right afterwards. Those three are important points: beginning, middle, and end of all of it. So when we arrive to a seizure, generally speaking, we're probably going to arrive when they're in their postictal phase, because they just don't last that long. And it takes the time it takes to get dispatched, to get in the unit, and then get across town to where it's happening. It may be over by the time we get there, the actual physical seizing there. But if they are actively seizing, then we need to get them to the hospital pretty quickly. If we're there when they are actually seizing, so we got a couple of things to do for them, to care for them while they're actively seizing. So we want to make sure that they're on the floor. We don't want them falling down and hurting themselves. any kind of restrictive clothing. If they got something around their neck, like a nice necktie or something, maybe loosen that up while they're seasoned there. Remove any objects that may harm a patient. So like if they're laying down right next to a chair or a table or something, maybe move that out of the way so they don't bang their head against it. Right? We want to kind of protect the patient's head there. Now, while we do want to protect the patient, we're not going to try to hold them down. We're going to let them seize. Okay, we're just going to let them seize, but we're not going to like try to pin them down or anything else like that. We're going to let them seize, and we're going to try our best to protect them from injury while they are. Now, there are treatments, and we'll talk about this in class. There's one called a vagus nerve stimulator. You can allow the patients to do that. It can have an effect in bringing somebody out of that. After the convulsions have ended, we want to protect the airway, make sure it's good. ABCs here, right? If they're cyanotic, then we want to make sure that they'll look at their work of breathing. Is it adequate or is it inadequate? If it's inadequate, then we're going to breathe for them with a BVM and some supplemental oxygen. Hopefully they didn't, but if they did sustain any injuries while they were convulsing, then we'll treat those and then get them to the hospital. Even with patients that have long histories of seizures, you want to take them to the hospital. You do. Even the person that's like, man, I've had these for like 30 years and this is normal for me. I'll be fine. You want to try to get them to the hospital. All right, here's a key point. It used to be, a long time ago, that when somebody seized, you wanted to put something in their mouth so they wouldn't bite their tongue. Well, if the whole body is like rigid in the tonic phase and then they start seizing, what could happen there is if you put something in their mouth, they could bite it, break it, and now all of a sudden there's something in the airway. Now we have an airway obstruction. So don't put anything in their mouth. Don't put your fingers in there. Don't put a pencil, a pen, nothing. Don't put anything in there, right? Because you might not get it back. And we don't want your finger to become an airway obstruction. So don't put anything in their mouth. Something to note here, if a patient has 2 or more convulsive seizures in a row without gaining consciousness in between, or a single one that lasts 10 minutes, it's called status epilepticus. And status epilepticus is a real emergency. And so if we know that, or if our history gathering says that this was occurring, we got to get them either ALS on scene right away, or we got to get them transported right away. Right? So that's know what that is. 2 or more seizures in a row without gaining consciousness in between, or having one seizure that lasts 10 minutes or longer. High priority. Get ALS, like I said, and get them to the hospital. All right, so there's some types of seizures here that we need to worry about. There's simple partial seizures. Sometimes it'll just be tingling, stiffening, or jerking of just one part of the body. These are the seizures that are affecting just its partial seizure. So these are simple partial seizures only affecting one part of the brain. So maybe just their arm locks up or something like that. Again, with the partial seizures, usually we don't see a loss of consciousness. Now we can, but usually we don't. These people may have an aura with no loss of consciousness, as we said. It can start as partial and then move to generalized. So the jerking and convulsions may spread into a full-blown tonic-clonic seizure. Complex partial seizure. These are difficult. These are difficult to nail down and observe. Frequently, people may have these, and nobody, including the patient, may know exactly what's going on. They can be confused. They can be staring off into space with just a glassy stare. They can be aimless with like their motions, the kind of lip smacking or fidgeting. I mean, all these things that, you know, people usually just do sometimes, and it can be very easily confused with normal behavior. So it's very hard to see these. These folks, they may appear drunk or be on drugs or altered in some way that's not normal there. So another question for those people that are off, and maybe you suspect alcohol or drugs, is, do you have a history of epilepsy? Have you had seizures before? So maybe they're not drunk or on drugs. Maybe it's something else that's going on. The patients are usually not violent, but they also don't like to be restrained either. So be aware of that if you and your crew need to restrain your patient. Again, you may have an aura as well. And no loss of consciousness here. However, they may not remember it, so they don't know what happened. So it's hard to see, it's hard to spot, it's hard to diagnose. Generalized seizures, we've got the two types. We've got an absence seizure. It's called a petit mal seizure. It's brief, 10-second temporary loss of concentration or awareness. Think about that. You guys ever just like daydream and just stare at a window for a few seconds? So these are getting hard to distinguish between some normal behaviors, aren't they? It can be difficult. It can literally happen hundreds of times a day as well. So when it's happening with frequency like that, it's much more obvious. It's something that would happen maybe once for a few seconds every now and again. So that makes it a little bit easier to spot. These petit mals, these absence seizures, petit mal seizures, they don't involve any muscle activity. It's solely located in the brain. You're just staring out into space for a little while. So that we have the petit mal, and then it used to be called the grand mal, or the tonic-clonic seizure. So we have the absence seizure, petit mal, or the tonic-clonic seizure, and we just learned about that. It involves the whole body and the entirety of the brain. Patients with seizures and their family members are often the best resource for knowledge about this. If they've had them before, then they know how things go. You know, we can talk to them about severity as compared to previous episodes and things like that. So they're really knowledgeable about it. They may even refuse transport. These folks that do refuse transport, they should not be left alone, because what if it happens again? And they definitely don't want to drive. You don't want to be driving and having a seizure. All right, let's talk about stroke real quick. Stroke is pretty simple. Pretty simple to understand. It's the death or injury of brain tissue from oxygen starvation. So, for one reason or another, somebody has a stroke, part of their brain is not getting oxygen, and so the cells are dying. And so it limits, depending on what area of the brain is not getting that oxygen, and we start to see symptoms associated with that area of the brain. Right? So maybe it affects their ability to speak. Maybe it affects their ability to, move their arms and legs, things like that. So there's two types of strokes that we need to worry about. The first one is called ischemia, an ischemic stroke. And we learned about ischemia previously, and that's basically just improper perfusion. We're not getting, blood flow is not getting to these cells. So an ischemic stroke is because of a blockage, right? A clot, some kind of embolism got stuck in an artery in the brain, and it's not allowing blood past it. So the cells past that, wherever that arteriole is or that artery is, they're not getting the oxygen, thus resulting in a stroke. The second kind of stroke is called a hemorrhagic stroke, and this is caused by bleeding in a blood vessel in the brain that has burst. So it's ruptured, it's burst, and so everything downstream of that blood vessel that blood vessel is feeding, because it burst somewhere, everything downstream of it is not getting that oxygen. So again, for one reason or another, A stroke is caused by those brain cells not getting oxygen. So it's either due to a blockage or a bleed. Those are two reasons. Hemorrhagic strokes, high blood pressure is bad. It's tough on all of your blood vessels to maintain such high blood pressure, and so they have long-standing battle, right? Somebody that's just hanging out in the 160s their whole life, they're 180s, 190s, way up high. These things happen. So you can often see people with strokes, elevated blood pressures. Not all the time, but sometimes. Can also occur when a weak area of the artery bulges, an aneurysm, right? Remember what that is, right? And eventually ruptures. So, signs and symptoms of stroke, we can take some of them and kind of put them in a book and be like, this is textbook, but it varies from person to person based on how much of the brain is being affected, how much is not getting oxygen, and what area of the brain is being affected. So maybe it's in the area that controls my speech and it affects my speech, but I don't have that hemiparesis, that one-sided weakness going on, things like that. So different patients will exhibit different things. So some of the common signs and symptoms here is one-sided weakness, which is called hemiparesis. It's one-sided weakness. So maybe somebody's entire left side is really weak, or they can't even move it. Maybe it's paralyzed basically on one side. They may have difficulty speaking or a complete inability to speak. This is called aphasia. Aphasia. This is a word that we need to know. It's one of the vocabulary words from this chapter. It's called aphasia, and it's difficulty speaking, basically, and there's different types. One type of aphasia is called receptive aphasia, and that means the person who's had a stroke, they're not receiving your words correctly in their brain. So they don't understand what you're saying to them because they're not able to process the language coming in that they're receiving. That's receptive aphasia. Expressive aphasia means they can't get the correct words out. Right? So it's two different things, but they might not be able to get the correct words out of there. It's, again, called aphasia, and a couple different types there. They can have a rapid and nasty headache caused by that ruptured blood vessel. We can have deviation of the eyes, so we can have one eye going off to a side there. You may have some visual issues too. The inability to recognize parts of the patient's own body. And so this is kind of part of like the aphasia thing where they may not be able to get the right words out. They're not able to recognize some things, common everyday things, like a telephone, a shoe, a house. They may not be able to tell you what that is. And they may not even recognize parts of their own body, which is crazy, right? Like, this has been my body the whole time. This is the only one I've had. Now all of a sudden, that's not my leg. That's not my leg, right? Like, that's weird. So, but it tells you what kind of effect the loss of oxygen to the brain can have. Communicating with the patient can be really difficult because it affects word use. So they may not understand the words we're saying, and they may not be able to get the right words out. So they may not be able to communicate with us very well. So having those bystanders around is always really nice. Family, friends, things like that. Again, aphasia, general term for difficulty communicating. Right, so I did this a little early. So expressive aphasia, the patient knows what they want to say, but they can't use the right words. They can't get them. It's not working. They know what they want to say, and it's frustrating for them too. They'll recognize this, but it can be very frustrating for them. It's scary too. Scary. Receptive aphasia, patient can't understand you, and so they'll respond in ways that don't make sense. Like maybe they'll respond like they just ignored the question that you just asked them. maybe they'll kind of pretend to know what you're talking about, things like that. So it can make communication real difficult. All right. Let's see. Other causes. There's something called a TIA, is a transient ischemic attack. Oftentimes, this is called a mini stroke, and where the patient here exhibits the signs and symptoms of a stroke, but they go away completely in 24 hours. And so they can show all the signs and symptoms from very minor to significant, and then they're gone, or back to normal within 24 hours. A lot of times this is as a result of a small clot that gets stuck somewhere in the brain, and then it breaks up and moves along, and then all of a sudden blood flow is restored to those areas of the brain that were getting ischemic. Symptoms, again, resolve when the clots break up there, and the period of hypoxia is short. So the brain cells aren't killed necessarily, so there's no permanent damage. So that's why things are back to normal within a day or so. Now, this patient is at risk for a full-blown stroke. Right? And so if you get there and they're like, you know what, things were crazy, I had all this weakness, my face was drooping, whatever it might be, I couldn't speak right, I had slurred speech, but now I'm fine. I don't need to go to the hospital. Yes, they do. Yes, they do. They should be going to the hospital to get a full evaluation there, because clots, emboli, they come from somewhere. And so what if that little one, this TIA, was just, a sign of what's coming down the road? So they need to get transported. Those folks, TIA folks, even if they're feeling fine, they need to get transported. All right, so we're going to talk about how we evaluate these patients real quick. We're going to use the Cincinnati Pre-Hospital Stroke Scale. This is really easy to use. We can use the anagram FAST to figure this out. I got some handouts for you guys. So F, face. We're going to look at their face first. And we want them to smile real big, right? Or like grimace or smile. And what you want to tell them is, listen, smile as big as you can. Show me all your teeth. Smile as big as you can. When it's really, exaggerated like that, when they smile as big as they can, then you can start to see signs. Maybe there's weakness on one side of the face, and so when they smile, hey, one side of the face is down. Smile on one side, not so much over here, right? So you might be able to see that. On one side it's good, one side it's bad. So ask them to smile really big. Show me all your teeth. Smile as big as you can, right? And if we got any drooping, the smile isn't symmetrical, you can tell if the face is working or not when you're looking at them like that. So an abnormal response is unequal or abnormal, or there's no movement whatsoever if they can't smile. Next is going to be A, and we're going to look at their arms. What we want to do is have the patient close their eyes and extend their arms straight forward for 10 seconds. What this is going to do is going to show us if there's weakness on one side or not. The patient's arm, on whatever side may be weak, is going to start to drift off. Okay, they won't be able to hold it out there. Now, the reason that we want them to close their eyes is because if they see that this is happening, they're going to try to correct it, right? And we just want it to happen. We just want them to close their eyes and watch it drift away. We'll watch it drift away. They should just keep their eyes closed, though. So abnormal response is for one arm to drift, or there's no movement for the arms either. All right, so here's stroke grandma. She is hanging out there, so we're going to have her close her eyes, put her hands up, arms extended, and we're going to wait about 10 seconds for that to see if we notice any, if we observe any drift, their arm drift. So she got one arm, it obviously drifted off, and it even turned over. So she started palms up, now she's palm down, and that right hand is much lower than the left. So we can see the rotation of the arm, and then we can see the arm drift downwards as well. All right, the next thing that we're going to do is speech. This is the S part. So we did face, arms, and now speech. We're going to have them say a sentence, and this is the specific sentence in which we want them to say. The sentence is, you can't teach an old dog new tricks. This sentence is actually, it's not just, hey, just have them throw something. If you read this sentence out loud, what I want you to do is pay attention to what your tongue does inside of your mouth while you're reading that sentence. You can't teach an old dog new tricks. Go ahead and say it. Say it out loud, but pay attention to what your tongue is doing. Your tongue is all over the place in your mouth. It's all over the place, right? And in normal speech, it does such a wonderful job of doing that, and so our speech is clear, it's not slurred or anything else like that. If we're having hemiparesis, one-sided weakness, things like that, the mechanisms to speak could be affected, right? Not just the parts of our brain, but we could actually have mechanisms here because the muscles aren't working right, and so we get slurred words. So you want that nice and clear. Now, if you're not sure, if you got an old person, they don't have their dentures in, or something like that, ask somebody that they know. Is this how they normally speak? Maybe they have a lisp or something like that, and they slur a little bit. Ask somebody. Is that how they normally speak? Does that sound, like your husband, ma'am? Is that normal for him? That kind of thing. You can't teach an old dog new tricks. So we're looking out for obviously slurred words. You can't teach an old dog new tricks, something like that, where they're clearly slurring their words. Wrong words, inappropriate words, or no speech whatsoever, or bad findings. Here's stroke grandpa. He's got the tongue protruding on one side, mouth open, weird gaze going on there. So slurred speech is definitely one of them. All right, so those are the three things that we need to know about. So face, ask them to smile. Arms, 10 seconds, the arms out, extended, palms up, eyes closed. And S, we ask for speech. You can't teach an old dog new tricks. And then the T for fast, to wind it all up, is when was the last time this person was seen normal? You have to know when these symptoms started, okay? So that's fast. I'll have a handout for you guys. The Cincinnati Pre-Hospital Stroke Scale, same thing. So T, face, arms, speech. T for time. How long has this has it been since this patient was seen normal? When was the last time you weren't having symptoms? Alrighty. Other causes of altered mental statuses. There's lots of different causes, as we've been talking about. Other signs and symptoms, they can fluctuate in severity. How bad they are. So they can be highly confused or a little bit confused. Remember, I had the lady that grew up in this town, or didn't grow up in it, but she was living there for like 40 years, and she lived in her own house for 35, she had said. And she didn't remember how to get home, but she knew where she'd just come from, what her day had been, everything else. Everything else was good. So there can be different levels of confusion there. Dizziness, lightheadedness, numbness, weakness, paralysis. That's often one-sided there for the strokes, is the paralysis there. So we can see all of this with stroke, which is what we're still talking about. because it affects muscles all over the body, you know, with the one-sided weakness and all that kind of stuff, we may see a loss of bladder control, and we may see a loss of bowel control as well. Impaired vision, like we talked about. High blood pressure. You know, a lot of times with heart attacks and strokes, this is accompanied by high blood pressure. It's been years of high blood pressure, somebody living with high blood pressure for a long time and not doing a good job taking care of it. Difficult respirations, snoring, right? If they've got half of their body that's not working, right? You know, one-sided paralysis, I think that's going to affect their work of breathing. Yeah, totally. They only got half their muscles working for them. It might be really hard for them to breathe. We can get snoring too, because if we're having all these muscles affected, like they're not working, well, then they're going to really be relaxing in the back of the airway and things like that, the structures back there. And so we can get some snoring. You can hear like the flesh basically vibrating because it's lost muscle tone back there as well. You get the snoring respirations. Nausea and vomiting is another one. Anytime there's like head injury, any kind of injury to the brain, we can expect nausea and vomiting. Seizures is another one that falls right into that category as well. Unequal pupils. So on the side of the brain that has had the stroke, you might see a blown pupil, which means it's very, very big. They'll be unequal. One eye will be very reactive to light. The other may be very sluggish in reacting to light. And you may just see a normal sized pupil, and the other eye, it's blown. It's really big. You see that. Headache, loss of vision in one eye, unconsciousness, that's less common. That's going to be pretty severe for a stroke. The most important thing when we're talking about patient care for strokes is recognition of it happening early. It is the most important step, because these people have to get to the hospital for care. Time is brain. Just like with a heart attack, where time is heart muscle, time is brain. The longer this condition is going on, the greater chances there are of the brain suffering permanent and irreparable damage. So recognition of the signs and symptoms is primary. It is so important here. So there are conditions that can mimic stroke, but if you find somebody that has the signs and symptoms of a stroke, you know, treat it like it's a stroke, treat them like it's a stroke. Maybe it's over treatment for whatever it is that's mimicking it, but just treat the stroke, treat it as a stroke if they're showing signs and symptoms there. Again, stroke is time sensitive, so we got to get to the hospital quickly. The longer there's a bleed, the longer there's a blockage, the more time than that, those brain cells are getting oxygen, the more ischemic they get. As we know, there are specialty centers. So if you want to make sure that your decision is to transport to the correct place, we want a stroke center. For us, it's Augusta Health here. So it's often that's your best decision, is to these are load and go patients. Okay? Again, time is brain. The more time between when symptoms start and definitive care happens, the greater the opportunity for permanent damage, even worse, to happen. All right, so patient care. For those that are conscious, calm them, reassure them, be there for a little bit of support emotionally. Make sure their airway is good. Again, we may have loss of muscle tone along much of the body, and so we could have an airway closing up because of loss of muscle tone there. Give them oxygen if they're below 94%. Never let them get to 100% though. Keep them at 99% or below. We talked about this with AMIs, that a patient can suffer a reperfusion injury and it can make the stroke actually bigger. So if they're below 94, give them a little bit of O2, but keep them below 100. Transport them as quickly as possible. For the unconscious patient, it's much the same, except we're going to have to do more protecting of the airway. So we've got to maintain that open airway there. They're already at risk. We don't know how much loss of muscle tone they're having or paralysis that they're having, and so we got to do the work here. Don't just assume that they're going to be able to, even though they're unconscious. And we should never, frankly, never assume that the patient, an unconscious patient, can maintain their airway. So maintain the open airway. Give them some O2 for the adequate oxygen saturation, again, between 94 and 99% there, and transport to the appropriate hospital. It's pretty simple there. Now, for these folks, be careful. If they're nauseous and vomiting and all that kind of stuff, they may have a real hard time doing it. And so maybe left lateral recumbent is a good position for them. Get ready with suction, things like that, all right, to protect and maintain that open airway. So some use of the treatments for these patients, like clot busting drugs, let's say they have a clot in an artery in the brain that's causing the stroke. They need to get these drugs on board very quickly. They're time sensitive. There are some that are as little as 3 hours. I think there's some now that are with protocols are up to 8 hours. There, I know this says onset of stroke is less than 3 hours. It depends there. All right, so again, context matters, time is brain, get them to the hospital. Again, for either they can either get in there and stop a bleed, or they can give them the clot busting drugs. They are time sensitive. The whole situation is time sensitive. So these are always load and go patients. We'll do everything on the way to the hospital. Once we figure out what's what on the scene, let's get out of there. Let's get out of there. And then obviously we want to make sure we know the exact time when symptoms started as best that we can. All right, a couple more things. We'll talk about dizziness and syncope. They can be indicators of serious or life-threatening problems. And you may not be able to diagnose what it is. Syncope, as we learned, is basically passing out. We may not be able to learn why they're altered. We may not be able to learn why they passed out. We may not be able to know why they got dizzy, but we can treat the underlying symptoms there, if not the main problem. So just keep an eye out for that. Figure out what the patient means by dizzy. Are they just not thinking right? Are they confused? Or are they literally like they can't keep their balance, right? Are they experiencing some sort of vertigo sensation? Are they weak? Do they have the vertigo? Do they have lightheadedness? Things like that. Syncope, it's a passing out. It's a brief loss of consciousness and they come out of it on their own, usually relatively quickly. Sometimes they have a warning that it's coming on. Like, oh, here it comes. I don't feel so good, and then they go out. Right? They may have some warning there. They can experience like lightheadedness and dizziness, vision changes, profuse sweating, like all of a sudden they're just really sweaty. Sometimes when people pass out and they have a syncopal episode, they pee themselves or they defecate themselves as well. There can be causes of this, so cardiovascular diseases. Maybe they were in an irregular rhythm that dramatically decreased their cardiac output for a few moments, and that caused them to go unconscious. If their heart rate goes too slow, like let's say they have sick sinus syndrome, that's a problem with the SA node there in the heart, and maybe that's not regulating the heartbeat well, and so now they go bradycardic, the body responds poorly to it. Maybe their heartbeat's beating too fast, and the heart can't fill up with enough blood, so cardiac output goes down, oxygen perfusion goes down, they pass out. A heart attack, an MI can cause it. Abnormal heart anatomy, so maybe if the heart is swollen or it's enlarged, they have problems with valves, things like that. Sensitive carotid sinus, again, thing. Stimulation of the vagus nerve, vasovagal syncope. We talked about this. You have like that older person that's sitting on the toilet, they're struggling, pushing to go to the bathroom. You know, maybe they've got a urinary tract infection, maybe they're constipated, something like that. When the vagus nerve is stimulated, it drops the blood pressure, and so when they stand up, the body's blood pressure is already so low, it doesn't have enough pressure to keep the blood going to the brain when they stand up. So what happens? They pass out. Right? So that is a vasovagal response that they're having there. Low blood volume, so hypovolemic, so severe dehydration or bleeding can cause that. Their internal, external bleeding, you know, caused by trauma or otherwise. Metabolic and structural causes, so that means inner and middle ear problems. Our inner ears are responsible for many of our balancing, for our ability to balance there. So if there's inner ear problems, maybe they're just dizzy, things like that. Hypoglycemia can cause dizziness and syncope. Stroke, seizure, all these kind of things. Kind of makes sense, right? All these things are going on in the brain. Environmental and toxicological causes, alcohol, booze, drugs that affect the central nervous system. So like, let's say we've talked about heroin a lot, right? And what it does to the brain and how it makes things, shuts down the breathing centers in our brains. So it'll have a response there. Carbon monoxide poisoning causes dizziness and passing out. Panic attacks, anxiety attacks, other causes. In a lot of cases, we just don't know. We just don't know. There's so many reasons why somebody can be dizzy or somebody can pass out. So keep an open mind, do your detective work, dig in, and hopefully we can find it. And if we can't, then we have to just treat them. It's just kind of like supplemental treatment there, keep them comfortable if we're transporting, give them oxygen if they need it. If they fell when they, passed out, then we'll take care of those injuries there. So some important questions to ask. What do you mean by dizziness? Did you feel this coming on? Did you have any warning that this might be happening? When did it start? How long have you been dizzy? People can be dizzy for long periods of time. There, it doesn't have to be just a short period of time. How long did it last? When they were passed out, how long were you out? How long were they out for? The person themselves may not know. What position were you in? Were you sitting down on the toilet and then you stood up? That might tell us things. Have you had this happen before? Some more questions. Are you on any meds for this? Did you have any other signs or symptoms? Right? We can always ask. That's a great question. Like, has this happened to you before? Yes. Are you on any meds for this? Maybe that can lead us directly to what the problem is. Did you witness any unpleasant sight or experience a strong emotion? So people can pass out from fear and being excited. I'm sure we've all seen a video of somebody being very excited about something and passing out, or being scared and passing out, or something like that. So those things can absolutely happen. Did you hurt yourself when you passed out? Bystanders, were they moving? Were they shaking on the ground? Let's make sure that they didn't have a seizure here. Right? All right. Their greatest danger is falling when they're passing out. Usually the body resets and they wake up on their own within a few minutes. And so make sure that they're in a safe environment there. If somebody did fall, make sure you go, and they're not there at the spot where they fell. Like maybe they fell in the bathroom, and then later when you get there, they're in the living room. Make sure you go to the spot and see what's the floor made of? Could they have hit their head on a corner? Is there any marks that their body left on the way down? Right? Is there any blood on the corner of the door or something? Go in there and look for clues like that. If they're real dizzy, things like that, let's try not to have them stand up. Right? We don't want them to pass out, so maybe we can lift them up into the stair chair or directly onto the cot there into a seated position. But let's keep them safe. Let's try not to have them walk downstairs or anything like that. If you do have to have them walk and standing up, then make sure you tell them beforehand that, well, one, well, first of all, if you're moving them, make sure that you and a partner are stable, on a stable platform to help this patient stay upright. And that if they feel that they are going to pass out, tell them to go to tell you and then to sit straight down. Just sit straight down. Like, oh, okay, I'm going to pass out. And then just have them sit right down. All right. And you can help control them down to the floor there rather than them just going, right, and hurting themselves. So we don't want that, obviously. So we'll provide aftercare. Give them oxygen if needed. Um, check the blood sugar. Also, if somebody's passing out, check the blood sugar. We should be doing that too. Provide some aftercare. So treat any injuries, lay the patient flat, give them some oxygen if need be, loosen any clothing, make them feel comfortable so they can breathe. They're not feeling claustrophobic. Administer oxygen based on our findings here. Call for ALS if needed. Treat any injuries. It's pretty simple. All right. So there's the chapter there. Make sure you go through the chapter review here and in the textbook. The quiz is out. It focuses primarily on diabetes, hypoglycemia versus hyperglycemia, along with questions about stroke and other causes for altered mental statuses. If you have any questions, just let me know. And we will see you guys next time.